great honor for me to address this august audience. I'm grateful to the organizer for inviting me for this interesting topic. So, respected chairperson, I'm going to talk for the next 20-25 minutes on various aspects of ECG findings and its different patterns in chest pain, particularly when patient comes to our emergency. So, our goal of today's discussion will be predominantly on acute chest pain patient presenting in emergency, how to differentiate between cardiac and non-cardiac, particularly our importance on assessing regarding the ischemia and ischemia, different ECG patterns in chest pain, and ECG localization in acute coronary syndrome. And if time permits, then probably we will have 4 or 5 slides on chronic chest pain in OPD, how do we differentiate from cardiac and non-cardiac, particularly on EMT basis, but probably we will need another class for that. So, when the patient comes to here, the most important thing is to triage the patient. So, let us first know which is an unstable chest pain. An unstable chest pain patient is one who is having hypotension with tachypnea, severe respiratory distress, with tachycardia and hypoxia. So, in these all cases, before coming up to any particular diagnosis, it is important to take care of the ABC classical protocol of the emergency medicine. So, what are the different causes of chest pain when patient visits to ER? Grossly, there are 4 types of causes like heart and blood vessel related like ACS, aortic dissection, pericarditis, GI causes like GERD, peptic ulcer disease, esophageal spasm or esophageal rupture or Wheeler syndrome. Particularly for lung and respiratory causes, pulmonary embolism, pleuritis, pneumonia, pneumothorax, and some musculoskeletal causes are also there like osteochondritis, rib fracture, shingles, and panic. But remember this mnemonics, there is a MIT. First, we should triage according like myocardial infarction, tension pneumothorax, aortic dissection, pulmonary embolism, and esophageal rupture. Because if we are unable to diagnose any of these, the patient might ultimately die. And before taking any brief history of chest pain, it is important again to know this mnemonic Socrates from our MBBS days, that how to take a history of chest pain, understand the site of pain, onset, character of pain, duration of the pain, associated symptoms along with pain, timing and duration, exacerbating and relieving factors, and the severity of the pain. So, we should remember this and take the history accordingly. So, what is an angina? It was classically described by Sir William Haverden long back. It's a pressure, squeezing or heaviness kind of sensation. It's retrosternal and not poorly localized. So, hence the patient will not be able to localize it with the finger rather than in a diffuse nature and usually not on cardiac critical area. And it radiates to jaw, shoulder, arm or epigastric and often brought on by exertion or emotional stress, cold exposure or postprandial exertion. It is usually relieved by rest or nitroglycerin, but in case of ACS, like when patient comes to ER with ACS, then sublingual nitrate will not be able to relieve the pain of the patient. And anginal pain is not sharp or pruritic, and it is not reproducible with palpation, which is of more like costochondritis. So the cross 3 patterns of ECG we get in ACS is a unstable angina or ischemic SCAMI or new onset LPPV. A new onset LPPV is basically a SCAMI equivalent. So before going into different patterns, let us first know about the coronary circulation in brief. Why it is coronary? Because the anatomy of the entire coronary system is resembling the king's coronation, which is named as coronary circulation. If we look at the picture, it's a very schematic and simple one. The left coronary artery, the left main artery, it's originating from the left coronary sinus and dividing into left circumflex and the main important the left anterior descending artery. Left anterior descending artery is giving branches, the septal artery is going to the septum and some diagonals going to supply the lateral blood and then continuing towards the cardiac apex. Whereas the left circumflex is going through the left atrioventricular groove, going backwards, providing some branches, that is the obtuse marginal to the lateral, and then going downwards and continuing with the posterior atrioventricular groove. In the right coronary artery, whereas it is originating from the right coronary sinus, and then it is giving branch, the acute marginal branch in the right ventricle, and then going downwards, providing in a branch that is a posterior descending artery, if it is a right dominant, which is in 85% of the cases, and then continuing and anastomosing with the terminal part of the left circumflex at the level of the cardiac class. The thing is that in rest of the 15% cases, there is almost 8 to 7% cases, this PDA originating from the left circumflex, that is what we call the left dominant circulation, and sometimes it's a co-dominant circulation where we got multiple PDAs originating both from the RC and the LCs. Whatever the blood supply of the conduction system, it is important to know that the LED is supplying the right bundle branch and along with the left anterior fascicle, whereas the left posterior fascicle is supplied both by the PDA and the LAD. AC nodal artery is originating from most of the cases from the right coronary artery, but sometimes also from the LCX and sometimes from both also. AV nodal artery is predominantly originating from the RC or PDA branches, but sometimes even from the LCX as well. What are the different coronary artery territories? This is again important to know, otherwise we will not be able to correlate with the localization. If you see over here, this is the echo picture of the parasternal long axis view. Just correlate with this picture. This is the left ventricle, this is the aorta, this is the left atrium, and this is the part of the right ventricle. So if you see over here, this lower basal part, that the infrabasal part, is being supplied by the right coronary artery, the left dominant circulation is by the left circumference. This upper part, is the interventricular septum, is predominantly supplied by the LAD, that is the left anterior descending artery. And the part of this apical part is again, which is missing in this picture, is also by the LAD, and another this part is predominantly supplied by the LCX. Let us come to the next image. This is the parasternal soft axis view. This is the cut section of the left ventricle. You will see over here, just correlate with this right upper panel picture. So these are the two papillary muscles. This lower part is the inferior part. This is the lateral part. This is the posterior infralateral part. This is the anterior part. This is the anteroseptal part. So this part is predominantly supplied by the LAD, that is the left anterior descending. This part is by the RCA, and this part is the LCX in broad term. Let us come to the fourth chamber here. This is the left atrium, this is the right atrium, this is right ventricle, and this is the left ventricle. So this is the interventricular septum, this is the interatrial septum, mitral valve, and tricuspid valve. Correlate with this picture, you can see over here. So this part is predominantly supplied by the left anterior descending artery. This basal part of the septum is by the RCA, and this lateral basal part is by the LCX, that is the circumflex artery. And the last one, that is the left ventricle two-chamber view, where the predominant focus is on the left atrium and the left ventricle only. Here you can see, if you correlate with the right lower panel, this part is predominantly supplied by the LAD, and this part is predominantly supplied by the PDA, mostly from the RCA. With this background, we all know that the basic pattern of the different ECG leads. The extra thing that we should know that to identify RV, that the right ventricular infarct and others, it is important to take some leads in the right side also, which is just reciprocal to the left side. This is the V2R, V3R, V4R, V5, and this is the same level and all other things, but exactly in the right side. And it's also important to know about the posterior leads, which is reflecting the LC stage over the posterior part of the left ventricle. This is the 7th, 8th, and the 9th lead. It is in the same level of the V5 and V6. V6 is located at the level of the mid-axillary line. This V7 is in the posterior axillary line. V8 is at the scapular line, and V9 is in between this spine and the lead 8. So ultimately there are 12 ECG leads we all know. The reflection is just like this. The inferiorward looking leads are the 2, 3 and 8 so we do get changes about the RCA over here, and if it is a left dominant circulation, then the circumflex will also be reflected over here. The high lateral is a 1 and AVM. Here we get some changes which related to LAD also, diagonal also, and the OM also. The AVR is very important in this regard regarding the left main coronary artery related changes, and the entire precordial leads is mostly determined by the LAD, but the lateral part can also be determined by the circumflex, and the V1 is also related to the proximal RCA2. And if we take the right sided leads, that is the V3, V4 and VR that we have already discussed, is mostly related to the proximal RCA, where we do get changes related to the right ventricular myocardial infarction, and we are taking the posterior leads in the V7, V8, V9, then we will get the changes related to the left circumflex coronary artery. So what are the time frames? That in initial few minutes to hours, we will get some changes related to the hyperacute T-wave changes in acute coronary occlusion. Then subsequently we will get the ST elevation followed by Q-wave, decreasing of the R-wave amplitude and the ST segment elevated part. Then gradually there will be T inversion with deepening of Q-waves. Then subsequently T-wave recovery will be there, while the Q-wave will get deepened, and persistently there will be, if there is a LV aneurysm morphology, we will get a deep Q-wave along with the persistent ST elevation with positive T-waves. And if there is reperfusion, then we will get some T-wave related changes, and ultimately there will be possibility of complete normalization of the ECG if it is timely reperfused. There are different types of ST segment elevation we can get in ECGs. So it's not mandatory that all ST elevation with concavity is found to be pericarditis related. It all depends upon the clinical parameters of the patient's presentation along with the vascular territory it is supplying. Let us come to the anterior wall myocardial infarction, the garden variety. The LAD is the most important culprit artery over here. All the 8 parts are related to this anterior wall myocardial infarction. There can be 4 classical patterns like extensive anterior wall, anteroseptal, lateral or apical. Here we do get a picture of an extensive anterior wall ACS, all are stable. You can see over here the ST segment elevation in one AVL along with all the precordial leads, and along with that there is reciprocal changes in the inferior quadrilateral leads. Here the LAD, the block is proximal to the septal and the diagonal branches, so the entire LAD territory is jeopardized. You get ST elevation in one AVL V1 to V6 and ST depression in 2-3 AVL. So the block is predominantly at the level of this part. Just after the AM bifurcation, LCX and LAD. So at this level, we do get an extensive anterior wall state. What about the anteroseptal wall ACS? So here the block is most of the times in between the septal and the diagonal branch. Here we will get an ST elevation in V1 to V4 and obviously the reciprocal ST segment depression at the level of the 2-3 AVL like the previous one. Then we come to the apical myocardial infarction, but sometimes we get this picture only ST elevation in V5 and V6. Here it is a distal LAD occlusion, distal to the septal and the diagonal branches, more in the terminal part of the LAD. But again, remember, sometimes we get some picture of staining involving the entire anterior wall along with the inferior wall. It is mostly because of wrapped up LAD, that is what we call the type 3 LAD, where in some patients this LAD is so big that it is not terminating at the level of apex, it is going even towards downwards and more towards the PDA and anastomosing with the PDA over here. So what will happen? It is supplying both the anterior, anterolateral, apical and along with some part of the inferior part of the cardiac wall. So ultimately we will get changes both in the anterior and the inferior that we call the wrapped up LAD. Here if there is some occlusion in the LAD, we will get pictures of both precordial and inferior wall changes, that is what we call the anterior inferior myocardial infarction. What about the LV aneurysm? Sometimes if not timely revascularization is done, there will be thinning and ultimately aneurysmal dilatation of a particular portion of the left ventricle wall, and that is what we call the LV aneurysm. Here you get a picture of a Q wave along with a persistent ST elevation. So these are the group of patients who may again come with chest pain for some reason, maybe related to the ischemic heart disease or something else. But it is difficult to pick up whether it is only from this ECG because already there is a baseline ECG changes in this group of patients. So the thing is that there will be no reciprocal changes in LV aneurysm related ECG and no dynamic changes will be there, only DQ wave and ST elevation. Let us come to the inferior myocardial infarction. There are different patterns of inferior myocardial infarction like isolated inferior involvement, infero-posterior involvement, inferolateral involvement and the RV myocardial infarction. Let us come to the inferior ACS. Here, in the right dominant circulation, all these blue colored things which are deflected over here, these are related to this inferior myocardial infarction. So the culprit vessel is mostly the RCA. We will get an ST elevation in 2-3 AVF with reciprocal changes in V1 to V3. You can see over here in this ECG, there is the classical ST elevation in 2-3 AVF. Here I will give one tip that if the ST elevation is more in lead 3 than the lead 2, the culprit vessel is predominantly right coronary artery, and if the reverse, that if the ST segment elevation is more in lead 2 than the lead 3, then the culprit vessel is mostly left circumference. Again, you will get an ST segment depression reciprocal in V1, V2, V3 over here. Here is a picture of an inferior myocardial infarction in echocardiography. How does it look like? You can see over here, this part is not moving correctly. Also, the hyperechogenicity because of the some edema of the myocardium, and this part is contractile normally. So this is an inferior myocardial infarction. How do we identify them in echocardiography? And many of these patients are having also mitral regurgitation, which you can appreciate over here. This reverse J through the mitral valve from the left ventricle to the left atrium. There is a significant amount of mitral regurgitation over here, which is mostly associated with inferior myocardial infarction. Remember that sometimes aortic dissections can present with inferior myocardial infarction. The dissection in the aortic wall can proceed within the RCA and can culminate into inferior myocardial infarction also. Here in this echocardiography, you can see over here there is a flare which is moving within the proximal part of the aortic root. This is an aortic dissection flare, and here this is the still picture of the same thing. This is an aortic dissection echocardiography. What about the inferolateral Acute coronary syndrome. The infralateral, the ST segment elevation you will get in 2-3 AVF and 1 AVF. It's mostly related to the dominant LCX OM1, but many times you will get the isolated lateral wall myocardial infarction also, which may be because of LCX OM1 D1. This particular territory has got a different variant kind of presentation in ECG, predominantly because of which vessel size is the only determinant thing. Because sometimes LCX may be small, but the OM is bigger. Sometimes LCX, OM both are equivalent size. Sometimes both the territory is smaller, but the D1 is larger. So everything depends upon the particular culprit vessel, and accordingly we get different patterns of pictures in the ECGs. Many times in 50% of cases we might not be getting any ST elevation at all, but also it is possible to get only in 1 AVL ST elevation, maybe in V5, V6 also. And most of these patients are having association with the posterior myocardial infarction. There is a posterior myocardial infarction in 5% of the SCABI you are going to get it. It is mostly related to the left circumflex and OM1 branch. You can see in this cross section that this is the posterior wall. Hence, you will get positive or elevated ST segment predominantly the posterior legs. There is a V7, V8, V9 in the posterior part, and you will get the exact reciprocal changes in the anterior wall. That there will be an R wave tall that we have learned from our MBBS days that the tall R wave cause in V1 is the posterior myocardial infarction. ST segment dictation is also possible in V1. But exactly the reverse, you will get the classical STEMI pattern in the posterior facing leads. But remember, as you are getting, because most of the times we are not taking this V7, 8, 9 in our regular day practice. So you will get only ST segment dictation in V1 to V3. So what will happen? It will resemble to some extent the classical anterior wall ischemic kind of pattern or reciprocal changes of the inferior wall STEMI. So it is difficult to pick up unless you are suspecting it and taking care of the posterior leads. What about the RV myocardial infarction? In 50% of the inferior wall myocardial infarction, when there is the occlusion is more proximal of the right coronary artery before the acute marginal branch, getting this RV myocardial infarction. The classical presentation is hypotension, raised AVP, but with clear lungs. But sometimes these patients are also having atrial infarct that may cause the atrial fibrillation. Mitral regurgitation is also a close association with it, and because of mitral regurgitation, patient can have failure also and lead to hypoxemia. So these are all associations with the inferior wall with the RVMI. Here, as it is a right-sided involvement, so you will get an ST elevation in V1, which will decrease as you go leftward. So the ST elevation in V1 will be more than the ST elevation in the V3. Whereas if you take a right-sided lead like V3, V4, you will get more ST segment elevation in the right-sided leads. So you will have to again consider in inferior myocardial infarction regarding the involvement of the RV and should take a right-sided leads also. And here the ST elevation is more in lead 3 than lead 2 because of the RCA involvement. So this is an RV dysfunction in inferior myocardial infarction. We took the TAPSE, we got that the TAPSE was relatively less. Again, this is the inferior wall involvement over here. So all these are the summaries that I have discussed over here. Some other correlates you will be able to see is a complete vessel localization with respect to like the patient has presented with shock. It may be because of extensive anterior wall AMI. There can be multivessel disease, mechanical complications like VSR, ventricular septal rupture, or the mitral regurgitation. Then again, mitral regurgitation is predominantly mostly because of the PDA involvement or also maybe LAD LCS. It happens because of the papillary muscle dysfunction. Ventricular septal rupture, if you can see over here, these are anterior myocardial infarction patient in the right-hand channel, right-hand panel. There is a pitch in the distal part of the IVS, where is a definite flow. This is a patient of the anterior STEMI with an extensive anterior STEMI and the rupture of the interventricular septum. So these are the very serious kind of complications that we can get in this group of patients. The CHB, complete heart block, may be a presentation in RCA proximal involvement. Sometimes LAD disease, where the extensive anterior wall AMI can have CHB pattern also, where there is a dominant septal branch and the block is proximal to that. And this group of patients, after this diagnosis, the prognosis is extremely dismal because almost 90% of these patients die. AVR, the importance with respect to chest pain, AVR is in ST segment elevation. It can be in case of the Lehman disease or sometimes in pericarditis you will get reciprocal ST elevation with respect to the ST depression in the other leads, which is concavity not following any vascular territory, and also PR segment elevation in other leads may be depression in the other leads may be reflected as a PR segment elevation in AVR also. which is here this ECG is particularly a patient of a pericarditis. You can see over here the ST segment depression with PR segment elevation here that will give you some clue about the pericarditis. So ECG pericarditis patient present with chest pain. There are four subsequent changes. At the initial phase, there can be ST elevation with concavity, with the PR segment depression. Again, ultimately there will be ST and PR normalization followed by T wave inversion and ultimately normalization of the ECG. Don't confuse with the benign early depolarization, where the patient are mostly asymptomatic and no dynamic changes. But on the pulmonary embolism patients also present with chest pain many times. Here the classical, the S1 TT33 is most of the times we don't get only ECG picture of sinus tachycardia many times, but otherwise we can also get some RV strain pattern also. Now let us know about something on view. There is a OMI and NOMI, there is a OMI and NOMI. Earlier, when we used to classify all the ECGs as a stable and end stage, we have got almost 30% of the patients who are classified as an end stage. But during coronary angiography, we have found that they are a very critical kind of block, either is a complete block or sometimes a near complete block. So the OMI, there is the occlusion myocardial infarction is a concept where a branch of the ACS algorithm representing near or total occlusion with insufficient collateral circulation causing active infarction. Whereas in NOMI, there is a non-occlusion myocardial infarction, there is a sufficient collaterals and no occlusion, and there is less chance of infarction. And these OMI patterns must be recognized. So, like we know about the stemming, nowadays we should know about this OMI pattern because these are the group of patients whose ECG patterns is something different, but we must pick them. Let us know about the first pattern. There is a hyperactive T-wave ECG pattern. You can see over in this ECG that the T inversion in AVA. There is a broad-based symmetric T in the lead 2 and also in the lead 3 and AVF, which is classical of the hyperacute stage of the hyperacute T in ACS. Let us know about the Whelan syndrome. It comes in two patterns. Type 1 pattern, you can see over here there is a biphasic T in the V2, V3, and the type B pattern where is the T waves in the other precordial leads. There is one patient of the Whelan syndrome around a few weeks back I got. It's a classical biphasic T wave, and when I did the angiography, you can see over here very significant amount of block in the left anterior descending artery. At this level, we should also know what is the ischemic T inversion and the LVH strain-related T inversion. In the ischemic T, the T wave inversion is mostly symmetric, whereas in LVH strain pattern, you will get the LVH pattern in the ECG along with asymmetric T. The classical apical HCM also has got a deep T. Again, it is most of an LVH strain kind of, not ischemic kind. What of the de-winter ECG pattern? Again, there is an OMI pattern of ECG here. It's a stereotypic ST depression in the precordial leads, along with a very hyperactive T waves with ST elevation in the LVR. This is again a pattern of the de-winter ECG. Many of this patient ultimately shows the ECG pattern of classical atrial valve ischemia after a few hours. What is S-Langer's pattern? This is another pattern of the occlusive myocardial infarction. Here, the ST segment elevation in the lead 3 is associated with ST segment depression in V4, V5, V6, and some ST segment elevation in V1, which is less than in V2. In V2, there will be no ST segment elevation. So, this pattern has also been described as an S-Langer's pattern. It is particularly relevant to patients who are having multivessel coronary artery disease but presenting with inferior wall infarction. So the culprit patient is mostly inferior looking, but patient is having multivessel disease. What about South African flat sign? Here this is predominantly the culprit vessel is a V1. You can see over here the ST segment elevation in the 1 FEL and V2 and ST segment depression in the lead 3. This is the South African flag sign, predominantly high up state. Sometimes in terminal QS discussion, in ST segment elevation without S wave, but at the initial sliding of the QRS is also being described as a OMI pattern. Actually, these are the very early stage of the hyperactive T because it is gradually rising, then ultimately will lead to the hyperactive tall T, and then there will be ST segment elevation. So these are the different phases and times. LPPP myocardial infarction, many patients can present with the LPPP first time with ACS, but also patients are having LPPP already and presenting with AMI. It's difficult to pick up, but there is a Garbosa criteria where accordingly, if you can risk stratify, you can score them. If the score is more than 3, you will be able to pick up the myocardial infarction over here. What is the criteria? That if in LVBP you can see in one AVL, that is the ST segment where the QRS complex is predominantly positive, whereas in V1, V2, V3 the QRS complex is predominantly negative. So by this knowledge, if there is a concordant ST segment elevation where the QRS is positive, more than 1 millimeter is considered as 5 points. In those leads where the QRS complex is negative, with concordant ST segment depression more than 1 millimeter, we should consider as a 3 points. And if it is a discordant too much high ST segment elevation more than 5 millimeter, it is considered as a 2 points. If the point is more than 3, then it is what we call a Garmosa positive, as a possibility of ACS in the background of the LPBP. There is some quick modification also, which is basically nothing but the elevation of the ST segment if it is one-fourth of the QRS territory. In those patients who are having pacemaker, they are having the paced LPBP pattern. We can use the safely you can use this Garmosa criteria for this group of patients also. You will be able to pick up ACS in this group of patients. Sometimes how to pick up the old myocardial infarction in the background of LPBP, that is what we call the Cabrera sign. You can see over here in the V2, V3 or the V3, V4, in the ascending lead, there is a sliding at the initial first 40 seconds, 40 milliseconds. There is a sliding of the QRS complex, that is what we call the Cabrera sign. If it is there, you are probably dealing with a patient of old myocardial infarction with LPBP. But as a Chapman sign, again it is to pick up the acute myocardial infarction in LPBP. Here, there is some sliding of the R wave in 1 AVL or V5, V6 in the ascending lead of the R wave. But remember, both this Cabrera and the Chapman sign are less sensitive. New bifascicular block, if the patient is presenting with chest pain in the ER with bifascicular ECG, then probably you are dealing with a very early stage of the LAD involvement, more in the proximal part of the LAD, because I have already told that the RBBP and the left anterior fascicle are supplied by the left anterior descending artery. So both the fascicles and the branches are involved, so there is a bifascicle. One of the precordial sweep pattern, sometime in the LAD, you can get this pattern with the ST elevation in V1 and V2 and ST depression in V5, V6. There is a precordial sweep pattern. Sharp field ECG pattern, or sometimes called the tombstone ECG pattern, the very gross ST elevation. It is basically marching of the QRS and the T wave all together with the ST elevation, so it looks like that. But importance is that it may mimic hyperkalemia, it may mimic white complex tachycardia if the patient is having associated sinus tachycardia. It is difficult to pick up, so remember the clinical background of the patient and then you should correlate accordingly. Left mid disease, multiple leads ST segment depression along with ST segment elevation in the AVR, and this elevation in the AVR will be more than the V1 that goes more in favor of left mid disease. And then subsequently you can go for the various biomarker studies like TROP-T, D-dimer, chest X and echo to pick up the actual cause. So mind some tips, like sometimes patient of ACS may present in ER with atypical angina or angina equivalents like dyspepsia, vomiting, dyspnea, etc. Atypical presentation is more common in female patients, elderly patients and diabetic patients. Esophageal spasm may mimic angina and can respond to sublingual nitrates also. ACS patients can have in 28% cases a normal looking ECG. You should take care of the clinical part and the TROP-T and others. So the take home is that ECG is the baseline pillar in chest pain evaluation. Identification of the high risk cases is the goal, and comprehensive holistic approach is the key to the success. Disclosure is a sponsored driven session, sponsored by the board end, and I got no personal benefit with this session, but this conference has largely been benefited academically because of their generous help. So I'd like to share 4 or 5 slides on their behalf with permission of the organizers. So we know that the angina that we have already discussed is related to the atherosclerotic obstructive coronary artery disease. Chairperson, I will take just 1 minute. And it may be related to the occlusive coronary arteries, but also can be because of vasospasm, microvascular dysfunctions also. Long-acting nitrates have got some dysfunction, issues like endothelial dysfunction, intolerance, and tachyphylaxis. And from different trials, it has been found that the long-acting nitrates, when being used after ACS for a long time, has been found to reduce mortality. So this nicorandil has got some added advantage that it not only acts through the nitric oxide pathway, but also causes the opening of the potassium-sensitive ATP channels, which acts as the sensitization to the ischemia. And in different trials, like in IMR trials, it has been found to be effective in reducing the coronary events. In JCAT study, the conclusion was that there is a reduction of the cardiovascular MACE with nicorandil use, And those patients who are having diabetic and underwent the elective PCI with the regular use of nicotine, there was much benefit. The ultimate outcome in an OSC study has got a mortality benefit also. So definitely the nicotine has got some added advantage over the long-acting nitrates. It has got associated with no tolerance, no cross tolerance, no endothelial dysfunction, and no. Thank you. Is there any specific question?